welcome to you all on this pleasant morning. And it's so good to see you, so many people here. So today we are going to discuss a very challenging topic.
किस तरफ से ट्रांसलेशन करवाई ना उनके साथ
So today we are going to discuss a very interesting, challenging topic which involves the management of age-related infertility and people with poor ovarian reserve. Traditionally, it has been thought that women are born with set number of ovarian follicles, and around the time of menopause, their ovarian pool is completely exhausted. But this is not the case. Research has indicated that women have dormant follicles, stem cells, which remain in their ovaries even after menopause. And the pressing problem is how to activate these dormant follicles so that they achieve maturity and the patients can then get pregnant. So these are the learning objectives of my presentation. Briefly, we will revisit the significance of ovarian reserve and factors affecting it. We have to define the poor responders using different criteria. I'll be discussing the role of PRP in ovarian rejuvenation and outline the method of performing PRP, and then we can review the available evidence relating to PRP for ovarian rejuvenation. So what is ovarian reserve? Ovarian reserve, it describes the functional potential of the ovary and reflects the number of quality and the quantity of oocytes within it. This is very important to explain this concept to your patients because आप किसी 25 साल की लड़की को कहें कि तुम्हारा तो एग्स तुम्हारे अंदर ख़त्म हो गए और जाओ और IVF करवा लो, तो this is very disturbing. She will think that what nonsense you're talking. So you have to empathetically approach these patients and you have to explain them how women are born with set number of follicles and it keeps on, they undergo atresia, sometimes they get atretic very soon. So you have to have empathy for these patients. So the factors affecting the ovarian reserve are, we all know that it is age, genetics and environmental variables. Age is the single most important indicator of fertility potential. तो मैं अपने पेशेंट्स को बताती हूँ कि आपकी मैक्सिमम फर्टिलिटी इज अराउंड द एज ऑफ 24-25 and then it slowly starts declining till the age of 35 years and then after 35 years it declines very rapidly. It goes down very rapidly. So this is a slide which represents that age, it is a very important factor. Then there is a difficult group of patients who suffer from premature ovarian insufficiency. And what is premature ovarian insufficiency? When a patient has amenorrhea, estrogen deficiency and elevated gonadotropins before the age of 40 years. And 20% of the time it is familial and 80% of the time we don't know the cause. Why patient is suffering from premature ovarian failure. So these are some putative causes of premature ovarian failure. It could be because of chromosomal factors, like Turner syndrome, Fragile X syndrome, or genetic factors. It could be because of autoimmune diseases. It could be iatrogenic because of chemotherapy, radiotherapy, or surgery. It could be autoimmune factors, and it could be because of environmental insights. So in IVF, we have to identify those patients who can show poor response response to ovarian stimulation. And these are actually classified with the help of dogma or mosaic and stratification. I'm not going to give the detail of this criteria, but both of these criteria consider patients' age and their ovarian parameter, reserve parameters, and there is previous response to ovarian stimulation to define these patients, because some patients may have normal ovarian parameters, ovarian reserve parameters, and normal, they may be young patients, but they still show poor response to ovarian stimulation. So this is Bologna criteria, and then we have Poseidon stratification. And these classification helps us to decide the best protocol for the patients. We to select the best protocol of ovarian stimulation. So we have to help out these patients, and how we usually use different medications to help out these patients. We can use arginine, growth hormones, we do estrogen priming, sometimes we use glucocorticoids, we add DHEAs to their protocol, we use coenzyme Q10, हम ये सारी चीज़ें जो है melatonin वगैरह use कर रहे होते हैं. लेकिन there is a new innovative treatment which has evolved during last 10 years, and that is ovarian rejuvenation. And what we mean by ovarian rejuvenation? Ovarian rejuvenation, it's an innovative concept, and it contributes to the balance of FSH, LH, AMH and estrogen levels. It restores the hormonal levels of the patient, and it helps in reconstitution of menstrual cycle. It even improves the fertility of the patients, and it actually turns back the fertility clock. It can help women to achieve pregnancy through either naturally or through IVF or ICSI. So who are the ideal candidates for ovarian rejuvenation? As I have said, that we can target aging women more than 35 years of the age for this therapy, or women who suffer from premature ovarian aging, usually typically younger than 40 years of the age, or women who have low ovarian reserve, low AMH levels because of iatrogenic factors or surgery. Or we can also do ovarian rejuvenation for those patients who, in spite of being young and in spite of having normal ovarian reserve parameters, they exhibit poor response to ovarian stimulation. And I'm sure that you guys must have come across such patients too. So what are the methods for ovarian rejuvenation? So it could be, it is PRP, then we can do PRP of the ovaries, we can go for stem cell transfusion of ovaries, and we can also go for IVA. IVA is in vitro activation of ovaries, in which they take out strips of ovary laparoscopically, and they expose these strips to certain hormonal biochemical stimulators, and then they re-stitch them back into the ovaries. So this is a newer therapy also. So today our talk will focus on platelet-rich plasma. So what is platelet-rich plasma? Platelet-rich plasma is a blood component where the blood of an individual is subjected to a specific laboratory techniques to separate the platelet-rich part from the platelet-poor part. So what do platelets do? Platelets, actually, they have alpha granules in them, and they have been found to be rich in bioactive substances. Platelets contain more than 30 bioactive substances, which are growth factors and cytokines, which can help in wound healing and tissue regeneration. So the main factors are epidermal growth factor, which can lead to cellular proliferation, vascular endothelial growth factors which can promote neoangiogenesis, transforming growth factors beta 1, beta 2, which can lead to cellular differentiation. And all these factors help in growing the follicles from the dormant follicles, they can convert into active follicles. So PRP is lately, it's a therapy which is becoming very popular in anti-aging therapies, in hair regrowth. It's been used in dental applications. Even it is being used for wound healing, like it is also used for bed sores and other kind of wounds, for soft tissue regeneration in orthopedics, and we as a gynecologist are utilizing it for endometrial and ovarian rejuvenation. So how do we prepare PRP? All the protocols, we have you may find lot of protocols in literature, and all protocols, they all follow a generic sequence that consists of blood collection. Then we initially centrifuge to separate the RBCs. Then subsequently, there is another centrifugation to concentrate the platelets and other components. And then we have, very important, to activate this sample by adding a platelet agonist. So for centrifugation, we need to have optimal conditions, like we have to, with respect to different variables of the process, such as volume and sampling of the process, whole blood, number of spins, time period of centrifugation, and range of centrifugal accelerations. So this is a typical PRP kit. So why activation of PRP is important? Because activation causes the granules present in the platelets to fuse to the cell membrane, which is called degranulation. And thereby the different factors, the different proteins which are present in PRP, they are converted to a bioactive state. And these active proteins, they bind to the transmembrane receptors of the cells, target cells. And then it generates a sequence of events which will promote to convert an expression of gene sequence that can direct to cellular proliferation, tissue repair, and tissue regeneration. So what do we use for activation of PRP? Usually people use 10% calcium chloride or 10% autologous thrombin, or a combination of both, or they may use 10% collagen. And alternatively, we can do a freeze-thaw protocol, and we actually use freeze-thaw protocol in our protocols. So here you can see that activation of PRP, for that we need so many cytokines and so many growth factors. Primordial follicles to ovulation, it can take around 90 to 120 days. So when we are doing PRP, we should expect the results in 90 or 120 days. We should wait after PRP. It's important. We should not expect that the next month we will get the result. So this is the protocol which we are using at our center. 18 ml blood and mix it with 2 ml anticoagulant. The anticoagulant which we are using is sodium citrate. And we take 10 ml in 2 test tubes, 10 ml each, and we centrifuge it for 10 minutes at this speed. And after that, we collect the supernatant of the platelet in a new test tube. Then we again centrifuge it to get a platelet pellet. When we get the pellet, then we save the supernatant, and we have to dilute it according to our requirement. For ovarian rejuvenation, we require 4 ml, 2 ml, 2 ml for each ovary, so we dilute accordingly. For endometrial PRP, we require 0.6 ml of the pellet, because in endometrium, if you inject very dilute fluid, then it's going to there's going to be a lot of retrograde spillage. For subendometrial, which we can do hysteroscopically, we require around 3 ml of the preparation. So we activate pellet by freezing at 4 degrees centigrade, and then we thaw it at room temperature, and we repeat this twice. Then it is ready to use. Then the next step is how to inject this PRP. And after activation, PRP should be injected within 15 minutes. So this is how to add the anticoagulant to the whole blood. Then after first centrifugation, we separate the platelet poor part from the RBC, platelet rich part from the RBCs. And then after centrifugation, we get a pellet, then we have to activate it, and the activated PRP is ready to be used. So this is laparoscopic. We can inject PRP by two methods, either laparoscopically or transvaginally. So laparoscopically, this is how we do it. And then transvaginally, it is done in the similar manner as we do the ovum pickup. But here the ovaries usually, the menopausal ovaries are usually small. And sometimes transvaginally it is very difficult to access these patients. Another limitation is when a patient has endometriosis or patient has very much adherent, there is pelvic pathology and the ovaries are very much adherent, then also it's very difficult to do PRP in such patients. So we have to select the patient accordingly. And the route of administration we have to select also, it is very much individualized. So this is summary. So what is the place of PRP today? So PRP, it's a debatable treatment, still it is debatable because it has unproven modality for ovarian rejuvenation, because there is still confusion over proper terminology to define, classify and describe the different variations of platelet concentrates, because in literature you will find that so many platelet concentration people are injecting, they have so many different protocols. There is also wide variation in the reported protocols for standardization and preparation of PRP. So we will see a review because of lack of time. I will not go in the details, but what is the evidence which is available in favor of ovarian PRP. So in ASHRAE meeting 2021, Dr. Antonio, he acknowledged that PRP is a possible modality for extending an ovary's lifespan. You can even find many articles in standard journals like Human Reproduction and Fertility and Sterility. I will not go into the details. And globally there are many ongoing clinical trials which will hopefully answer our queries in near future, that what concentrate of platelets should we use, what should be the amount of volume of PRP which should be injected in the ovaries, how long should we should centrifuge the PRP. So this is very important. So we will be getting answers soon. So here I would like to share our own experience with PRP. So this is case number 1. This is Mrs. S.A. She was 34 years old when she presented to us, and she presented with a history of primary subfertility for 2 years. And at the time of presentation, her FSH in January 2020 was 13 and AMH was 0.4. She was offered IVF, but she declined it. So she came again in November and she had a worsening ovarian reserve parameters. Her FSH was rising and AMH was going down. We gave her ovulation induction for 2 cycles in July 2021, but she was proved to be a poor responder. So she was not going for IVF. I offered her PRP. So her laparoscopic PRP was done in March 2022, and laparoscopy, she had patent use but small ovaries. In April, when ovulation induction was given, she showed a mature follicle, and in October 2022, she reported with a spontaneous pregnancy, positive beta HCG of 5,000, more than 5,000, and currently she has ongoing pregnancy at 20 weeks.
So this was our success. And this is another lady, and she had been married, this was her second marriage, since 5 months, and she was 39 years of age, Mrs. SHA, and she had her pregnancy, 3 pregnancies from first marriage, and her son was 18 years old. So when she presented to us in June 2020, her FSH was 14.7 and AMH was 0.5, and she had a poor antral follicle count. So in February 2021, she underwent IVF, and she was again a poor responder. Only 4 follicles were aspirated with a single oocyte that was of moderate quality. There was no milling factor involved. So the outcome was there was no fertilization and no embryo transfer. She was again a very poor responder. Then we did her laparoscopic PRP in 2021. And in December 2021, she came up with a beta HCG of 87.7, but unfortunately this ended up in an ectopic because she had a lot of, on laparoscopy we found that she had a lot of pelvic congestion and everything. But she got pregnant. She had such a bad response even with IVF, but she spontaneously got pregnant with PRP. So these are our success stories. So I would like to play a movie. Correct? Ji ji.
In your talk you said it takes about 90 to 120 days to get the results, but the 2 patients you showed, they conceived one in a month, the second is 2 months. So
2-3 months, I think it was September and December, so it was around 3 months. And the other one was done in, I think it was done in April, and she got pregnant in
in your
October.
talk you said 90 to 120 days to get the result, but the fee.
It might be, that is a possibility, because there are ongoing trials. What I am saying that there is lot of debate on this thing, that how long should we wait, because in literature you may find studies where they have done PRP and immediately they started the IVF cycle to see the outcome, but they are not finding results. And
I get it. The second question is, in which part of the ovary are you injecting? Anterior, posterior, lateral, what?
we are doing it in this, we prefer to do it in subcortical portion, but we do enter the medulla as well. Basically in subcortical portion and medulla, there is no hard and fast thing that we are doing it anteriorly or posteriorly, because the ovaries are so atrophic, you don't get a good volume.
How much amount are you putting in?
We are injecting 2 ml. But there is also debate on it. In literature, you may find people injecting 5 ml, people are finding.
In orthopedic, they do multiple.
Yes, that is my debate. That is my debate. Yes.
And in gynecology, are you also attending multiple?
I think we should, because after the ongoing trials which are ongoing globally, we will get an answer soon, because there is a lot of enthusiasm globally for this procedure, and logically this is a very cheap procedure. It does not cost you so much. It is relatively safer procedure, because this is all autologous. You are not injecting something from outside into the ovaries. So this is very, I think this is very interesting to know.
One attempt on patients.
We have done only 1 attempt, but I am encouraging certain patients to get another round of PRP as well, in whom we are seeing that their ovarian parameters are getting better. I am encouraging them, but you know, money is a big issue for our patients.
The last question, how much does it cost?
It costs in our center around 1,10,000, if it is. I want to show you a movie, how we are doing it laparoscopically. What level we have done, actually we are building up our own experience. We have even done in FSH more than 50 or 60. We have done it, because there are certain patients who would say that do our IVF, do anything you want to do to improve our ovarian response. So they have pushed us, but I have seen that once patient is more than 40 years, for more than 40 to 43 years, more than 40 we have results, but more than 40 to 43 years, and if the ovaries are very much atrophic, then we don't get any results at all. And ovarian parameters are very bad, like AMH is less than 0.01 or less than 0.02, we don't get any.
So you can always only the one time or you have done repeated times?
Only one time, only one time.
Is there any possibility that we can go for the PRP like we are going for the pickup by the transfer?
At the time of, I don't think so.
Is there any way to go like that?
We can do it. I don't think so, because at that time patient is stimulated. She is not in her.
Not stimulated, like in that way, rather than going for the via laparoscopy.
We are going transfer. Yes, we have done transvaginally as well. We have done transvaginally as well, but technically transvaginally it is difficult to identify the ovary. Ovaries are so small because at the time of ovum pickup, the ovaries are so much enlarged, and there are lot many follicles. It's easy to go into the ovaries transvaginally. But here, what is my experience is that ovaries are sometimes so small that it's hard to get in. So it's better to identify them laparoscopically and then go in.
So whenever you have been through the transvaginally, via same pickup needle or any other thing?
With the same pickup needle. With the same pickup needle. So this is how we do it. This is a small video.
मैं आपसे पूछना चाह रही थी कि अभी तक आपने कितने पेशेंट रखे हैं और उसमें कितने सक्सेसफुल थे? आपने दो स्टोरी सुनाई, और कोई जो
30
सक्सेसफुल हुए, और एक और मेरा क्वेश्चन है कि जिस तरह की स्किन और ये उसमें ऑर्थोपेडिक में सेशंस चलते हैं, एक से काम चलता है, आपकी
Yes, this is my debate. This is my debate that we have done around